Okay, hi, my name is Maripaz from Mexico City, and I want to present this work about post-surgical radiographic control of the orientation of the femoral and tibial tunnels in postoperative patients for reconstruction of the anterior cruciate ligament with all-inside technique. Like introduction, we know that the rupture of the anterior cruciate ligament is one of the ligament injuries that most frequently cause pain and joint instability, mainly caused by sport injuries or falls. An average of 150,000 ACL injuries are recorded annually in the USA. And we know that biomechanic of ACL injury is valgus or varus rotation, movement of knee flexion with standing. And this lesion is also associated with another sequels like meniscal injuries, chondral injuries, and early post-traumatic osteoarthritis. With the diagnosis, we have the pain, the joint swelling, the joint blockage, and knee instability in acceleration of deceleration. And we have a lot of diagnosis tests like the Lachman and pivot shift, but these are the most specific and sensibility for the diagnosis. And for the images, the study of choice, we have our resonance magnetic. We talk about the all-inside anterior cruciate ligament reconstruction. Lubowitz first described with the all-inside technique with ECL reconstruction in 2001, using a retrograde drill coupled with the joint through a small wide centimeter incision and a tibial hole and a femoral hole with interference screws to graft fixation. The all-inside technique consists of drilling holes instead of wide tunnels so that the tibial and femoral cortex remain intact. And this is important because we need to have the graft should be between 65 and 99 millimeters long. The ground leaf is the name given to the ready-made graft with a tie rope, implants, and its ends. The implant has a cortical fixation button and a graft lifting system that is self-locking at 4 points at the end of the procedure. And here we have images from the all-inside cruciate ligament, all-inside anterior cruciate ligament reconstruction. First, we need to have the femoral tunnel. Then we have to put with the tie rope. Then we have to put the tibial tunnel, and then we have to put the with the tie rope in femoral and tibial. Okay, well, we have a lot of methods for measure the ACL femoral footprint. The first method was described by Bernard, and he had like a quadrant method that in a 30 degrees of flexion of the knee, they have a quadrant with numbers. Then we have a Google parallelogram method and a Illingworth. And for this work, we will use the Illingworth measurements from the femoral footprint. Okay, the Illingworth. Here we have a radiograph of the anterior of posterior radiograph, and we have two lines. We have the line A and we have the line B in the shaft of the femoral. We have two, and we have another perpendicular line in the transepicular axis of the femur, and we have when we have the line, and then we have to have the femoral tunnel angle between these two lines. Okay, we talk about the methodology of our study. We have a retrospective and observational cross-sectional study in post-surgery patients with anterior cruciate ligament reconstruction with all-inside technique. The period of our study was July 1, 2080 to July 30, 2090 at the Hospital Español in Mexico. And the measurements were made in immediate and post-surgical AP lateral knee radiographics with 30 degrees of flexion. Okay, in the AP view of the knee, the orientation of the angle of the tibial tunnel in the relation to the tibial plate was taken according to Bern and Stutz, and to measurement declination of the femoral tunnel in the AP radiograph projection of the knee, the technique by use by Illingworth by use. And the radiographic with SPPS program for Macintosh. Okay, we have the inclusion criteria. Patient of both sexes who want to participate in the study, diagnosis of complete ACL rupture, clinical and bioimaging study, the age of less of 60 years, the study period from July 1, 2018 to July 31, 2019, complete clinical and radiological record. The exclusion criteria was patients with recent ACL revision surgery and radiographical projection with poor technique and patients who underwent anterior cruciate ligament reconstruction before 30 days from the date of injury and those who underwent to abandon the study. Like the results, we have a total of 10 patients, and here is the table from the results. I will show you the results in the next slides. Okay, we have 10 patients, 8 men, 2 women. We have 6 right knees and 4 left knees. The average waiting time for surgery, it was 17 days, with a maximum of 37 days and a minimum of 2 days, and with a standard deviation of 13.16 days. We use the Mann-Whitney U test to find the relation between the inclination of the femoral angle and the male or female sex with P of 0.533. And also we have the relation between the inclination of the tibial angle and the male or female sex with a P of 889, finding that the distribution of the femoral and tibial angles is the same in both sexes. A total of 7 patients underwent surgery before 30 days from the date of injury, and 3 patients underwent surgery after 30 days from the date of injury. The relation between waiting time was analyzed with the Mann-Whitney U test, finding that the distribution of the inclination of the femoral angle is the same in patients who underwent anterior cruciate ligament reconstruction before 30 days for the day of injury and those who underwent surgery after 30 days from the day of injury.